Good afternoon, Katrina. I'm so excited you're finally on the podcast. Welcome.
Hey, girlfriend. I'm so excited to be here. Thanks for having me.
Oh my God, absolutely. I am just so thrilled for you to be here and everybody to hear from you because one of my passion projects is getting hygienists to, at the very minimum, screen for airway. And
Yeah.
sometimes when we initiate these conversations, and I've gone to offices and I've had these talks, and I get it, right? I was a clinical hygienist. Their response is, really, you want me to do one more thing? And so
Uh,
I'm so excited that I really truly believe after today and listening to you and the way that you practice, that hygienists are going to realize that it is basically something we're already doing, just putting a different lens on. So to bring it back to the podcast, like putting your myo eyes on, right? Putting those airway goggles on. So welcome, and let's start off. I'm sure a lot of people listening already know you, but let's give a little bit of background on you. I want to know, you're known for being such a passionate and lively educator. So share with us how we like the first time you heard about Airway, how you got introduced to it.
yeah. Well, first of all, thank you again for having me on the podcast. And I love the concept of how do we take this and make this relevant to hygienists. And I think this is such a timely conversation for so many reasons. One of them being the fact that many hygienists like me graduated during a time when we did not learn about airway. We did not learn about tethered oral tissues. I knew a tori was. I knew to write it down on my head and neck exam. So again, early on, yes, we're looking for these things. We see these things. So I
Mhm.
was looking for them, but I didn't have that educational piece that linked and said, if this, then probably that. Or
Mhm.
if this, maybe we need to ask that. I
Mhm.
graduated at a time where it was still a really strong focus around aligning with CODA standards. That's the accreditation body in education, and then making sure that I was able to pass my boards. Check plus, we did that. I passed my boards. Here I am practicing almost 2 decades. And the concept of airway not being a part of my foundational education, I think improperly signaled that this was not a part of my scope.
Mhm.
And I hope we can get a little provocative later on in the pod and talk about scope and
Yes.
what hygienists should be doing, because that's a hot button issue right now. But I think for me, because it wasn't a part of my scope, and because I had graduated from hygiene school, and if we can all just go back there for a hot second, you graduate from hygiene school and you're just trying to get your speed up, right? You're just trying to, you're seeing your very first patients and you're like, oh, there's no instructor to check my work. Like, I'm
Yep.
just going to see
Yep.
you and dismiss you and okay, bye. See you in 6 months. And so
Yep.
that was kind of the rigmarole. That was my experience
Mhm.
graduating and trying to just figure out and assimilate into
Mhm.
dentistry. And I did not graduate and begin working in a practice that talked about airway. So again, it wasn't there, it wasn't present. It wasn't something I thought about. Even when I started teaching as a faculty member, it's not a CODA standard. So this wasn't something I was even educating my students on. And as a professional speaker, I spent so much time focusing on the important things that I thought dental hygienists needed to focus on, going back to basics of assessing periodontal conditions. I mean, airway alone, the the basics of like identifying periodontal disease and instituting a treatment plan early on in the disease process and not waiting until it's too late.
Mhm.
That's a foundational basic that we're still trying to educate a lot of dental hygiene professionals on today, which is wild to me. So I had spent all this time focusing on all of that.
Mhm.
And then for those of you who know my story, you know that I had the sobering moment of the universe, our creator, God, whatever you believe in,
Mhm.
creating this very humbling moment for me as not just an educator, not just as a dental hygienist, but as a human,
Mhm.
um, in losing my mother. So in October of 2018, my mom suddenly collapsed in the kitchen. She had been walking around that day, no problem, had gone grocery shopping with dad, came home, they were unpacking the groceries. Dad got distracted by filling up the bird seed and the bird feeder in the backyard, as you do in the Midwest. And when he came into the house, grabbing the last bag out of the car and closing the trunk and coming in to help mom finish unpacking the groceries, he found her collapsed on the kitchen floor. called emergency services, administered CPR on my mom. The emergency services arrived, transported her to a hospital in northern Wisconsin where mom and dad lived at the time. And they immediately placed her on life support and began running tests. And although one would expect that with something very sudden like this, very acute like this, she was just walking around and then she collapsed. The first assumptions are things like stroke and heart attack and pulmonary embolism. And when they ruled those out and began to dive deeper into her case, awaiting for her lungs to breathe on their own or for brainwave activity to occur, they recognized that there was something deeper to this. My mom had an airway obstructive disorder. And the airway in my mom's case had been so narrowed and almost cauterized with scar tissue that toward the end of her life, she had a strained breathing pattern. And, I kick myself because I saw my mom 6 weeks before she died at my grandfather's funeral, and I noticed her breathing was wrong. And I said something. I said,
Mhm.
Mom is not breathing correctly. But it was grandpa's funeral, and we were focused on other things. And
Mhm.
so I didn't speak up. I didn't do the thing. And oh gosh, if I could go back in time, if I could go back in time, but I didn't. And that strained breathing continued so much so that the morning that my mom died, that morning, she woke up and she felt like she was struggling to breathe, and she saw an ENT. And that ENT did a scope down her airway and said to my mom, Linda, you've got scar tissue in your throat. And you know that, and I know that. And we've been actively monitoring. Why did they not do anything about it? I don't know. We've been
Mhm.
actively monitoring this. That's normal for you. Here's a Z pack. They gave my mom a prescription for antibiotics, which is what prompted her to go to the grocery store, drop off the prescription, walk around, get some groceries, grab the script. My mom didn't
Mhm.
even take that first antibiotic. What's an antibiotic going to do
Right.
for this airway obstructive issue, right? And so the cause of my mom's death was that scar tissue had loosened up from the scope, had come up and occluded her airway, and her brain was without oxygen for long enough that she would have been in a
Mhm.
vegetative state, even if we could have gotten some kind of brainwave activity. And I will say we are devastated to have lost her, but we're very proud because several people are alive today and can see because of my mom's gifts of organ and tissue donation. And one other piece I do want to share about the beauty of this story, my mom was 62. Her lungs could not be transferred to someone else. They could not be transplanted. However, my mom was a never smoker. And my mom's lung cells were actually transported to the University of Wisconsin-Madison. I had mentioned she died in 2018. Her
Mhm.
lung cells were used to test COVID medicaments during COVID.
Wow.
Isn't that amazing?
Wow.
What an
Yeah.
incredible story, right? So, we're proud, and it hurts my heart that this is the way that I was introduced to Airway. I don't mean to laugh, but I mean, gosh, what a humbling moment to think about. Now, I never treated my mom. I did not hold a license in Wisconsin, but as I think about this, and the deeper I dive into understanding Airway and understanding the critical role, we think about the number of patients who are sitting in our chairs and suffering from airway issues.
Mhm.
My mom collapsed. I mean, she had an acute response. Um, this is truly life saving what we're doing when we talk about this. And I don't mean to be overly dramatic, but that is the reality of this. And I will tell you what was so hard, Brittany, is going home for my mom's funeral.
Mhm.
And my dad asked for help in cleaning up some stuff. And we were very sensitive. We didn't, he didn't want her clothes removed just yet. He wanted them to, okay, whatever you need, Dad, we're here. But he
Mhm.
did want her prescription bottles removed. And my mom was on GERD medication, and she was on medication for migraines and high blood pressure. And
Mhm.
when you looked over at her side of the bed, she had a stack of pillows.
Mhm.
Like she couldn't lay flat. I mean, all of these very obvious signs, like, oh my gosh, it was right there. And I have to think, I don't blame my mom's dental hygienist for this.
Mhm.
But my mom was going every 3 months for a perio maintenance, right? Like at some point, my mom's hygienist could have said, Linda, you're adding on these medications, you're increasing the dosages. This breathing isn't correct. We spend all this time staring down the airway of our patients, and I don't know head and neck exam wise what other modalities my mom had going on, but gosh, I'll say that was a moment for me to take a step back and to recognize that we assume that our ENTs are doing the thing, right?
Mhm.
Um, but they're not apparently. And I think about the number of times that patients come in and say, "Oh yeah, my cardiologist knows my blood pressure is high," and "Oh, my endocrinologist knows my diabetes is out of control." I mean, number one, do these prescriptions that are being called in by these physicians, do these truly align with the level of disease you have? Do these physicians actually know the level of disease that you have? I get the opportunity as a spectator to see you every 3, 4, or 6 months.
Mhm.
I get to watch, I get to see those changes. So it changed the game for me. And I'll say it is so amazing to see people like you, Brittany, having that conversation and continuing to share that message because it has to be shared. This is life-saving work, truly.
Oh my God, absolutely. And I feel like too, these ENTs, cardiologists, GPs, whatever, they're just chasing symptoms and putting band-aids
Yes.
on everything, right? Like we lost my father 2 Januaries ago, and his was a cumulative illness. I mean, he just was a very compromised guy, but my dad had heart issues since he was, I want to say he was 40, was the first stent he had placed in his heart. And he
Wow.
had 9 stents, 11, I'm sorry, 11 stents in his heart. 3 months before he passed, he had open heart surgery. And I remember as I was learning all of this, I'm like, I remember my whole life hearing my room was across from my parents, hearing my dad snore like a trucker. And I'm like,
Wow.
nobody's ever asked him how he sleeps. So I remember I fibbed to my dad one day. I was like, I got a disposable watch pat from one of my colleagues, and I was like, Dad, you have to take this. And it was like 2 weeks went by, he didn't do it. And I'm like, oh my God, you have to do it. Sky is going to charge me triple. They're going to charge her triple if this device reading doesn't get back. We have to do this.
That
And
motivates a
he did
dad
it.
to do something. Yeah.
Right, right. He did it. And the results came back moderate, OSA. And of course, he was like, I didn't even sleep all night. That test doesn't know anything. And I'm like, fine. You know what? We'll take these results, bring them to your GP. We'll get you in with a sleep doc. You can get an in-lab sleep study and we'll see what happens. So, long story short, he had the in-lab sleep study. It came back on the lower end of moderate. And he came home from the appointment and he was like, yeah, he said I'm fine. I'm like, what do you mean he said you're fine? He's like, yeah, he said, I don't have to do a CPAP. I don't have to do, XYZ. I can try to lose weight, blah, blah, blah. I'm like, moderate obstructive, any obstructive,
Yeah.
right? It doesn't even
Yeah.
matter that it's moderate. With your history, what do we think this is going to do for your heart all night long when you literally are stopping to breathe multiple, multiple, multiple times a night? So I called his sleep physician and
Wow.
I was like, hey, I'm just, I'm really interested. I know that I'm Italian. My dad is a very, very stubborn, was a very stubborn Italian man. And I'm like, I'm sure he probably gave you some pushback, but you did suggest that he go on a CPAP, right? He's like, well, I mean, he could, but he's on that lower end of mod. And I'm like, I'm like, my dad has at that point, it was nine stents in his heart. He had a heart attack. The heart attack we do think was caused by COVID, but still, and he had other comorbidities. It wasn't just the heart,
Sure. Sure.
nothing. Then, so just craziness. And my dad ended up eventually having pulmonary issues down the line. That's really what ended up, how we ended up losing him. But I have another story with my father-in-law. My father-in-law, he was overweight, or yeah, he's not overweight anymore. He definitely was diagnosed with high blood pressure. He didn't love going to the doctor. I don't think he was very honest with what the doctor suggested. I don't know actually if he was ever on medications before. I'm not entirely sure. But this man slept on the couch for years and years and years, would snore. Anybody could hear him no matter where you were in the house. Again, he goes in, he gains weight. I remember the spring before his stroke, his ankles were so swollen, his legs were like so purple. I
Wow.
said to my husband, I'm like, I don't know, that doesn't really look right to me. Anyways, long story short, nobody ever asked him either about his sleep, anything like that. My father-in-law had a stroke 3 months before our wedding, March of 2020,
Oh,
and he's still not walking or talking.
Oh
He
my gosh.
literally on a Sunday, I'm sorry, on a Friday, handed in his retirement. He was a teacher, 40 years. And on that Sunday, he had this massive stroke. And it's like, again, he went to the dentist regularly, and not just the dental professional, it's just that we see our patients the most. We're literally staring at
Yeah.
the areas, but even more so, why we should be doing it because nobody's asking about sleep. It doesn't matter what physician
Yeah.
you go to. And these things could have been avoided. I might have been able to have my dad around for a little bit longer. My father-in-law might be walking and talking today. And it's
Yes.
just, again, it's just so important. So I'm sorry again to bring up all this tragedy, but it is literally life-changing work. Like you said, we're
Yes.
saving lives. And it's just so important. So thank you for sharing that story. And I am so sorry for, the loss of your mother. And that
Thank
is,
you. I'm sorry for your loss, girlfriend. Oh,
oh,
that's horrible.
yeah, thank you. I appreciate that. I want to know, like, what does an airway screening look like for you in your hygiene chair?
Yeah, thank you for asking that. I want to talk to the hygienists listening to this because one piece that I continue to think about, and thank you for the candor of sharing your
Mhm.
family's story about this. The one piece I want to share is we do rely a lot on collaborations with our medical colleagues. My sister is a podiatric surgeon.
Mhm.
Um, and I will tell you, it's incredible. One thing that I don't think we in dentistry understand about our medical colleagues is that they are seeing very sick people all the time,
Mhm.
catastrophic illness. The images of I mentioned my sister's a foot and ankle surgeon. So the images of the lower extremities of the patients that my sister just normally, she's like, this is just a random Tuesday. And these
Right.
patients are like, I mean, I'm looking at this like, oh, is that pus? Are those maggots in that? And she's
Oh my
like, yep, this is a Tuesday for me. Like, whatever. I'm just gonna go grab my Starbucks and cut off this
God.
person's foot. Like that's normal for her. And
Right.
I think about our cardiologists, like they are so used to seeing I mean truly dying people. That's what's
Mhm.
happening when we think about the longevity of our patients' lives. We also miss the quality of life of our
Mhm.
patients' lives. And while, yes, we are living longer, we are also dying longer. If you
Mhm.
think about the back end of our patients' lives and the cocktails of medications that they're seeing, and when a patient goes into their cardiologist, I mean, it is quite rare that cardiologists are sitting there and patients aren't having major catastrophic issues. They don't get a patient who just like walks in, not out of breath, and yippee skippy sits down in the chair and starts
Right.
talking to you about, oh, the kids are at cheerleading camp and I'm going to go to vacation in Costa Rica. But we get that dentistry. We get that. We
Mhm.
get the opportunity to see now, yes, patients will come in and and there's a weird pimple over here and so we're dealing with some stuff. There's no question about it. We deal with people coming in pain and they got questions and, all that stuff. But for the most part, hygienists specifically, we are so well positioned because we are oftentimes not seeing patients in a catastrophic
Mhm.
state. It
Mhm.
is not, I mean, yes, things happen that we don't plan for during that hygiene hour. That happens. There's no question about it. But it's important to recognize that we are in a position to be able to expand upon things that, yes, maybe our cardiologists are going, oh, it's mild, it's moderate, it's not a big deal. We get to say, but here's the detail. Here's what we know
Mhm.
about prevention. And the thing is, we can't even fully calculate what happens when we put people into appliances or a CPAP and we can start to control these airway. What we prevent down the road is hard to quantify what that looks like. But as hygienists, we get the opportunity to do that. So let's begin with the beginning. Where
Mhm.
do we begin in that airway screening? I'm putting in quotations because the reality is it's not an airway screening. To me, it's a patient screening. It
Mhm.
begins with watching that patient stand up in that reception area and walk back. How are they walking? What is their posture like? Are they tipped forward? Are they standing up straight so that their airway is nice and straight? Do they have some of that skeletal malocclusion where it is very obvious early on? What about the bags under their eyes, right? Particularly our kiddos. Now, I work in a perio office, so I don't see a lot of kiddos. I got to tell you this story. I hope you'll be proud of me, Brittany. There was I was watching on Instagram the other day. This mom was recording this video of her daughter who's like 12 years old, and she was kind of making fun of her daughter. The vanity of these young girls these days was kind of the tone of the video. And this girl is like, Mom, I have wrinkles on my face. And she's pointing to, she's got these giant bags under her eyes, right? She's got these giant bags and she's pointing to them and she's like, Mom, I need makeup for the wrinkles on my face. And of course, I immediately like pull out my popcorn and go to the comments section. I'm like, oh my, here we go. And all these women, oh, kids are so vain. Kids these days, kids these days. Now I get on there, right? I'm like, hold my beer, right? So I get on there and I said, actually, to be very clear, it looks like your daughter has a skeletal class 2 occlusion. It looks like she's a vaulting of the palate. The way that she's speaking in the video, she's not articulating some of her words, her S's, her sound, which has me wondering if she has some tongue tie issues. I didn't see your daughter's lips close at all while she's speaking, and it looks like she's pointing to bags under her eyes, which a 12-year-old shouldn't have. I think instead of pointing to vanity for your 12-year-old, you might want to consider having your 12-year-old evaluated by a dental professional who is trained in airway. Okay, right away, just by looking at the person and watching how she spoke and watching skeletally, I can see right away something is not right here. So that begins for me right away. I'm just looking at the patient. Then we dive into medical history and the comorbid complications that we see in the perio space just so gorgeously align with airway issues, cardiovascular issues, endocrinology issues, diabetic complications, inflammatory issues, sinus issues, which, we're consistently looking at. So we're looking for a lot of those commensurate comorbid issues early on. That medical history becomes really important. And as I continue to see more and more of those modalities, even into things like reflux and gosh, when I was in hygiene school, I learned about GERD, and I learned if a patient has GERD, we should talk to them about fluoride to remineralize the teeth. I was not taught about, upper airway reflux issues and constant clearing of the throat and things like that, and how all of those are indicators of potential airway issues. So we're looking at those things on the medical history. I'm looking at the size and circumference of the neck of my patient. I'm looking for how big or even how muscular that neck circumference can be. I'm looking at vital signs, my patient's blood pressure. We do know that airway issues, poor sleep patterns, and high blood pressure do move in tandem. I'm looking at pulse ox. So we've got a little pulse oximeter that gets inserted onto the finger of the patient, and it gives me a very simple, non-invasive reading of the percentage of oxygen circulating in my patient's blood, which is a gorgeous indicator as to if my patient has an airway issue. So I haven't even tipped the patient back. I'm getting typical. I'm reviewing the medical. We all review that medical history. We all look at our patients, right? We should be looking at the color of our patient's skin, bags under the eyes, and things like that. Oftentimes, patients are doing things like, it's my 2 o'clock in the afternoon patient, and they made themselves a cup of coffee and they can't make it through the afternoon without their afternoon cup of coffee. They share those things with us, right? Or those indicate. So you're telling me you're a caffeine junkie. Okay. That's a good indicator there, right? So I'm looking at a lot of those modalities. All of those things, again, we're typically screening. Then we go intraorally. And yes, I'm looking for malocclusal issues with my patients. I'm looking for changes in my patient's airway. So we grab a Mallampati score, which is a score that gives me the tonsillar, base of the tongue, uvula relationship. It's not a perfect score. There's no question about it. It's not perfect. I've had a lot of doctors say, oh, you're going to use a Mallampati score. Yeah, it's not perfect, but it's a pretty good indicator of what's going on down that airway. If you try to look down the patient's airway, you can't even see what's going on back there because the base of the tongue is coming up. And if that tongue is scalloped, gosh, that is a gorgeous indicator that there is likely an airway issue going on. So I will tell you early on in all of these modalities, these are things that I'm looking for that are already on my health history form with my patients. These are vital signs that I'm already gathering. I'm just taking this a step further. Instead of taking my patient's blood pressure because I might be giving them a local anesthetic with epinephrine where I need to be concerned, you know what I'm saying? Now I'm taking this also to screen for other potential issues. When I'm doing the head and neck exam and I'm finding these, massive mandibular tori, this palatal oral torus. I'm looking at vaulting of the palate and things like that. I'm looking at the occlusal relationship. I'm not just looking for, could you be a good candidate for adult aligners? I'm looking at, what's going on with the orientation of the teeth subsequent to the tongue, and how does all of this fit together into a puzzle? I will say one of the most important pieces about all of this is, yes, I'm gathering this information. And I think we can all agree that there are different levels of degrees of how involved a hygienist can get.
Hmm.
I will tell you, you're only as good as your ability to say, something doesn't look right, and I'd like to send you somewhere to have this looked at. Best case scenario, you go, they give you a little ring, you sleep with it for a night, right? I mean, there's so many non-invasive ways to do this now. They give you a
Yeah.
little ring. Best case scenario, you go, they look at it and they're like, man, it's not a big deal. That's the best case scenario. And that's what I hope for you. I mean, we can talk about this with oral cancer, right? Oh, I don't want to scare the patient and refer this lesion to oral surgery and then have oral surgery go, oh, it wasn't a big deal. Isn't that what you want for your patient? Don't you want
Right.
oral surgery to go, it's not a big, are you telling me that you'd only want to refer if you know that oral surgery is going to say, oh yeah, this is stage 3 squamous cell. Yep,
Mhm.
yep, good job, you did it. No, I want my patient to go and get a negative reading. Good
Mhm.
job. So we've done all the things we need to do, and the good news is it's nothing. So that is
Yep.
best case scenario. And I feel like, I don't know, Brittany, don't you feel like that sometimes? We're like scared that if we send the patient and it's not a thing,
Absolutely.
that like all of a sudden we're the silly ones. Who are we to say? And I don't know. I've got a challenge with that.
Yeah, absolutely. I mean, yeah, again, we are never going to be wishing this upon our patients. We're hoping
Right.
they with that negative, but the times that it does come back, again, we're saving lives. And it is a simple, so this kind of like gets us into our next question too. Um, and you touched on it a little bit, but I guess how do you kind of connect the dots for the patient and make it not so overwhelming for them or even like confusing, right? Because they are coming to you and expecting a certain thing. And I know you've been integrating looking for airway stuff intraorally for years now, but for a hygienist that say they listen to this podcast and they're like, you know what, I'm going to start doing this on Monday. And then the patient's like, well, you've never told me that before. Like,
Yeah.
how do you handle those conversations?
Oh my gosh, I love this question. This is so, oh, chef's kiss. So anytime, so dentistry is so funny. Okay, let's just do like a tiny little way back playback. So breast cancer runs in my family. Both of my grandmothers had breast cancer. We lost one of my grandmothers to breast cancer. Another grandmother was a survivor. We lost her due to ramifications of Alzheimer's disease. My mom died too young for us to really understand like what her risk would have been.
Mhm.
So this is all just a very long story for before I was 40, before I turned 40. My OBGYN, I'm going in for my annual stuff, right? As you do as a woman. And she's like, hey, breast cancer runs in your family. In the past, we would have waited until you were 40. And there are a few reasons why we did that in the past,
Mhm.
right? Number
Mhm.
one, your insurance won't cover it until you're 40. Number two, and I guess the piece that I really want to amplify, number two, it used to be quite invasive to have a mammogram done, and women would commiserate about, oh, yeah, this and that. But my OB said a few things. Number one, we're talking about breast cancer here. And respectfully, because you have a risk, we're not going to wait until your insurance decides that it's acceptable. This is something we need to screen for. And I hope you're in alignment with that. We are looking out for your best interest. Oh, gosh, buzzword. We are looking out for your best interest. Like, gorgeous, right? Isn't that what you're doing? When you're looking at your patient's stuff, we are looking out for your best interest. I don't care what Blue Cross Blue Shield of Berber says. I'm looking out
Mhm.
for your best interest. That's what I'm trained to do. That's the oath I gave on my graduation day. Number one.
Mhm.
Number two, in the past, we didn't have this level of technology, this non invasive, this level of not whatever it may be. In the past, we didn't have this,
Mhm.
but we do now. So the whole mammogram dealio is like now we have this equipment that doesn't what I don't know whatever squish you as much or whatever the I mean I was like okay well sign me up for that all right and so she was basically saying like it's less invasive and so it allows us to be more involved in integrating this for our patients. So medicine does a really great job of being so proud of integrating new things and being like, yeah, we didn't, yeah, when you came in blah, blah, blah ago, or other women your age who had this risk, we wouldn't have done this. But you know
Mhm.
what? We're so proud. We have this new technology that allows us to. And oh, here is the buzz one. Here's the pearl. If you're driving, pull over to the side of the road, write this one down. We now know. We now know. Please. That is like the most gorgeous buzzword or a series of words that you can use. We now know. We did not know previously. Did we know in hygiene school? Pff, I didn't know, but we now know that being able to identify this, we now know that this plus this likely equals some underlying piece. And I like to help my patients understand my why. I don't think dental hygienists particularly do a good job of this. We get really scared about getting on the patient side of things and going, oh, they're not going to pay for it. They don't
Mhm.
value this. It's not important to them. They're looking away. I let my patients know, and I hope you'll consider hygienists sharing with your patients your practice philosophy, your why. So I let my patients know I treat every patient in my chair like a member of my family that I like.
Very
That's the
important.
important part. Yeah, that's the important part.
I got sharp tools in my
Yeah,
hands.
that's
Very
exactly
important.
it. Yes, exactly. And but I let my patients know that because here's the truth. Knowing my story. Now I sit and I look at every patient as my mom or my dad or my grandmother. And so I look at them through the lens that I wish my mother's providers would have. And so I let my patients know I treat every patient in my chair like a member of my family that I like, which means that I'm going to be looking beyond the 32 white things in your mouth. Here in our office, and I share not just my practice philosophy, but my practices practice philosophy. So I will speak on behalf of my employer, AZ Perio. In our office, we practice whole body health. That's what this is about. It is about whole body health. The reason why we have an extensive health history form is because we now know that your mouth drives a lot of the disease that you checked on this sheet of paper. And we also know that when you have these conditions, it immunocompromises you. Your immune system is like a battery. And so all of these things are draining that battery. And so this is going to complicate the success of your care. We deliver whole body health. So that's why we gather these comprehensive vital signs. This is why I spend time looking at your health history. This is why I might be sending letters out to your physicians. So I implore you to consider a lot of times, yes, patients will ask questions. And I think our lizard brains think, oh, the patient's judging me. They think that maybe I did a bad job last time. They're questioning the integrity of my work. They think I don't know what I'm doing. And maybe I don't know what I'm doing because doing airway screening is new for me. So, oh gosh, they caught me. Ooh, red handed, right? Maybe those are all the things that go through our head. Maybe instead, I want you to think about this. And I think this is a really good activity. Think about a healthcare provider that you've seen who did an excellent job. Think about that person just for a minute. I'll personally share last year, I had a pregnancy that ended in a very tragic pregnancy loss. However, during that pregnancy, I was considered a high risk pregnancy. And so I was referred to a high risk pregnancy OB, Dr. McCool. And Dr. McCool was excellent. And I think about what are the things that he did that made him excellent. Uh, well, number one, he cared first and foremost about me and my pregnancy. And he did say, we'll help out with insurance stuff. But he also understood the research and he shared that research with me. He came in with knowledge. He listened.
Mhm.
He answered my questions. I understand that you read this on the internet. Here's the challenge with that. He made me feel hurt. Think about a healthcare provider that you admire, somebody who did excellent by you or a family member, and think about what elements of that healthcare provider made them excellent? And how can you take and emulate those things to your patient so that I'm not, I don't mean to script you. I don't mean to be your ventriloquist puppeteer and say, these are the things you have to say. Now, there are some good pearls, there are some good communication pearls there, but even more so, think about the kind of provider you want to be and think about what are those elements of being excellent that not all patients want an excellent provider. That's the truth. That's the sad, hard truth. Some
Mhm.
patients just want the provider who will shut up and do the free cleaning, the insurance coverage, and then get out.
Yep.
You get to decide. It, are those the kind of patients that I want to be a provider to? Maybe this isn't a good fit.
Mhm. Mhm.
And so I think there's an amazing opportunity here for you to reclaim the power that you have in providing high level excellent care, and the reasonable patient should be grateful that you are taking additional steps and measures to protect their whole body health.
Oh my God. Absolutely. And this kind of goes into the other topic I wanted to discuss too. And I know this isn't your experience. I don't know how long you've been at the practice that you're at, or if you maybe had this experience somewhere else, but there are then those hygienists that want to provide this high level, standard of care, and they get the pushback from the office. Now, yes, of course, we can just say, well, it's not a good fit, go find a better one. But what else, what other advice would you have, like as far as like educating that provider?
Yeah.
Talk to me a little
Yeah.
bit about that.
I think that's huge. I do think dentistry, unfortunately, has like a matchmaking problem. When I graduated from hygiene school, it was, do you have two hands? Do you have a hygiene license? Great. Check and check. Can you work Monday, Wednesday, Friday? Like it seemed like if you could do it, you were licensed and your schedules aligned well, then
Mhm.
good, you can work in this practice. And I think that's like a big problem in dentistry. I think we need to spend a little bit more time saying, hey, what are your core, before you even get involved in a practice. Now,
Right.
once you're in the practice and you're there, that is challenging. I do want to kind of encourage you. Empathy is putting yourself in the shoes of the other person and truly wearing those shoes and looking around at the world around you in those person's shoes, right? So I want you to think about the practice owner, the doctor, for just a second. I'm just going to assume this is a doctor practice owner situation.
Mhm.
Doctor may not have the level of training or understanding in airway that you're integrating. And that can be a little bit uncomfortable when the patient then turns to doctor for validation of the stuff that the hygienist said. That can be uncomfortable. Um, and I don't mean to say that our doctors have egos, but maybe they do. Maybe they do. And are they expected? Are they expected to be the smartest ones in the office? Are they expected? They're the ones with the doctor. They're the ones with the name on the door. They're
Mhm.
expected, right? We work under their license. So they should be the ones that know even more than we do. And that can be really scary.
Mhm.
Here's the other challenge. And I think this is a deeper challenge that we're seeing now, particularly in practices with multiple hygienists. Patients can get a dynamically different experience depending on what chair in an office they sit in. And I recognize that the other challenge that a doctor practice owner has is attempting to calibrate.
Mhm.
That becomes really hard when you have one, I hate the term, but I'm just going to say it, rock star hygienist, where that hygienist is doing all the things, doing all the charting, taking the FMXs, updating all the da, 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 da. And what ends up happening, I think we can all agree, when that hygienist institutes that high level of care, the healthcare outcomes of those patients who got the whittle of the draw, got the jackpot, and ended up in that hygienist column on a routine basis, the health outcomes of those patients then become dynamically different. what you start to see are not just health outcome differences, but of course, even production differences. You've got a hygienist who's doing the correct assessments, which means typically taking the correct radiographs, billing for those things, instituting periodontal, et cetera, doing all of those different things. And so you end up, here's our power. What happens is you have a hygienist who starts warmly bringing these patients in and going, I understand that inflammation, chronic inflammation is bad. Acute inflammation is good because it means, okay, we're going to start to fix it. Chronic inflammation is bad. I understand. Okay, we need to treat this. Oh, so I need a crown over here. So I guess I'm going to go ahead and do. And so what starts to happen is we step into our power of really influencing change in our patients. I recorded this Instagram live the other day about my issue with Mel Robbins. I love Mel Robbins, but her new book, The Let Them Theory, it's not intended to be this way, but unfortunately, people are reading the let them theory as this concept of like, fine, if you don't want to brush your teeth, let them not brush. I don't care. And the reality is, ooh, hygienists were change agents. That's what we do. That's what we went to hygiene school for, is to
Right.
understand that we can influence that change. So we start to see these different dynamics. So put yourself in the shoes of the doctor and start to see and look around at, I understand this must be hard. This must be a challenge. Now, the good news is there's always a solution. The good news is if you are willing, doctor, to go on this journey of talking about what this will mean for our patients, not only will it mean optimal health outcomes, but gosh, we've all talked to doctors who have started to integrate Airway into their practices. And not only in my experience of speaking with those doctors, not only is it a massive production booster, these doctors are living well, but but they also find such deep meaning in their work. I don't mean to say that doing crown and bridge work is not meaningful, because of course it is. But there's something different about sitting with that patient, talking to them about their airway issue, having the patient go to the cardiologist. The cardiologist says it's not a big deal. Patient goes to a sleep center. Sleep center says, meh, it's mild, so we're not going to give you a CPAP. Patient comes back. Doctor in a dental practice creates some kind of an appliance that completely changes the way the patient breathes at night. And finally, the patient says, I wake up in the morning without headaches. I'm finally sleeping through the night. My wife says I'm not snoring anymore. That, in my opinion, creates something completely different from, are you happy with the PFM I put on number 14 for you? Is it chewing okay for you? You getting through Thanksgiving dinner all right? It's
Yeah.
just it's transformative. And so I think the opportunity, hygienists, is to have that dialogue with your doctors and say, I see there to be a massive opportunity. Show your doctors just in one column, these 8 patients I saw today, these 5 patients are all terrific candidates for airway management. And we are missing an important piece to that puzzle. And I would love to talk to you about what it would look like to integrate this into our practice for our patients, for practice boosting production, for the health of the patients and the health of the practice.
Yeah, that is a perfect dialogue, everybody. Just say what you just said. I mean, honestly, because again, it's, I hate to say it, and I think this does change when when practices become more airway focused. Um, it lights their soul on fire again, right?
Yeah.
Like they find more purpose in their work because maybe doing that, you know, crown and bridge work day after day. Maybe for some it's beautiful for their 40-year career,
Yeah.
or however long their careers, but for some it gets pretty redundant. And, I think that, so where I was going back with that is, oh my gosh, I'm losing my train of thought. Hold on. What was I saying? See, this is like,
I
I,
know this is how this goes. Yeah. We get so
brain, it's
excited
just
about it.
like at the end, as we trickle down to the end of the day, it goes,
I know.
I was saying that doctors, they have their soul on fire, but I was gonna say, oh my gosh, what was I gonna say? Oh wow, Katrina, this is bad.
Stay
Honestly,
tuned. That'll
it's
be our
gonna come
part
to me.
2.
It's gonna come to me. Come back. It's gonna come back. But until I'm gonna continue thinking about this, people, and it will come back to me, I promise, because it was a good
It's going to come back in the shower at like 10 o'clock tonight. You're going to be like, dang it, that's what I was going to say. Does that always happen to you when you're like, man, or like the really good comeback? Like that always like, Oh man, I should have said that. That would have been such a good comeback, you know?
You'll know that that happens when at the very end of this episode, there's just like this cut in version of me saying, and my my final thought was, okay, it is going to come back to me, but in the meantime, I want you, if you can, please, to give hygienists, like, again, maybe first time they're hearing about this stuff, they're, on board. What would be your top three things that hygienists can begin implementing tomorrow? That would make a difference. Now, that can be a question to add to medical history. That could be something in their EOE, IOE.
Yeah. I think let's do top three easy peasy things, like things that require the lowest effort possible. Question number one, tell me about how you're sleeping. Tell me about how you're sleeping. Now, that's called an open ended question because you're not saying, do you sleep well? Yes or no. You're saying, tell me about how you're sleeping. That's it. And you're waiting for the patient. Let the patient guide that conversation. They could say things like, well, I get up and I toss and turn. I get up to pee a lot through the night. My wife says that I snore. It takes me a long while to get to bed. I spend a lot of time watching Netflix before I get to bed. So, number one, tell me about how you're sleeping. Number two, tell me about how you feel when you wake up first thing in the morning. Tell me about how you feel when you wake up first thing in the morning. Again, open ended question. You're not saying, do you feel good when you wake up? Because you want to know. By the way, fun fact, friends, Americans, fun fact. I have to say this to Americans because we love to sensationalize this concept of like being over caffeinated and
Yep.
overtired and like
Yep.
all the time. We love doing that. But the reality is, you should wake up in the morning feeling refreshed. You should feel. You should not have a headache. You should not feel groggy. You should feel clear,
Mhm.
right? So tell me about how you're sleeping. Tell me about how you feel when you wake up in the morning. The final question I would ask is, has anybody else, or is there anyone in your suite of medical providers actively managing your airway and sleep pattern? That's what I want to know.
I love
Because,
that question.
right? Because you could have patients, some patients will say, well, I had a sleep test done. My husband, before we got married, he had a roommate, and his roommate is just as tall as he is round. And my husband and his roommate would go camping. And he was always like, oh, I don't, I love going camping, but like, oh man, he snores all night. And, I mean, just the whole thing. Right. And so I asked one day, I was like, hey, friend, have you ever had a sleep study? And he's like, yeah, I did, like, 15 years ago, and they didn't find anything. And I was like, well, maybe you want to update that. I don't know. You know what I'm saying? Like,
Yep.
so you might have a patient who said, yeah, I had a sleep study done 15 years ago and they didn't find anything. Well, do things change? Yes, of course they do. Or the number of times that a patient will say no, actually. And you're going to get good information from the some patients will say, you know what, I told my PCP and they gave me a prescription. They told me to take Unisom if I'm ever this and that. They'll tell you if
Mhm.
they are and the stuff they've been told. And
Mhm.
I will tell you, we are root cause providers. There's an
Mhm.
opportunity for us to do so much more.
Oh my God. And, there's a big difference between something on a medical history saying, do you have a CPAP versus are you actually utilizing it? Like, what
Correct.
is somebody managing this on the regular? Not you got a CPAP 10 years ago and you haven't seen a provider since.
Right.
And
Right.
it's
Or
just
did
so
somebody tell
important.
you? Did somebody tell you to take a CPAP and you're not doing it? And
Right.
by the way, are there alternatives to a CPAP or a BPAP? Yes, they are. The problem is, and unfortunately, we have limitations to what our medical community is going to do. Again,
Mhm.
they are so busy managing catastrophic issues.
I also remembered my thought. And I
Oh,
wrote it
yay.
down. I wrote like two words down because I'm like, you're going to forget it again if you don't. Okay. So where I was going with that was I feel like when, practices become more whole body focus, holistic airway focus, again, yes, it lights their soul on fire and there's meaning to their work. And I'm not saying that bread and butter dentistry, there's not meaning to it, but for some
Yeah.
it's not. For some, it just pays the bills. It's a very good right, profession. And I think that at the end of the day, when you're having these conversations with the doctor, because this goes back to how does the hygienist have the conversation with the doctor about integrating these type of screenings into their practice. At the end of the day, it is their business, right? This
Yeah.
business, it is what's putting food on their table. So it is not unfair that the doctor wants to see what is in it for them, right?
That's right.
It's a business. And I
Yep.
always say this to, when I teach my myofunctional therapy course and we're talking about referrals and going and having lunch and learns and, lunches and whatnot, I'm like, you can't just talk about what you're going to do for them. Like, or I'm sorry, the patients that you're going to send to them. How is this going to be a two-way street? How are you going
Yeah.
to help them grow their practice? And these buzzwords, they're buzzwords for a reason. People are Googling nasal breathing, tongue ties,
Hmm.
sleep
Hmm.
apnea, alternative methods to, CPAP,
Yep.
blah, blah, blah. This stuff is coming up. So you
Yep.
are going to be putting more bodies in those chairs. So there is for sure an ROI to your office for you to begin implementing these strategies. That's where I was going with that.
Oh my gosh, I'm so glad you remembered that because that is really powerful. And the reality is, yes, a lot of us think like, oh, all my doctor does is stuff for money and this and that. And again, the reality is dentistry is a business, healthcare is a business. But I think the deeper layer to this is when we're able to do more for our patients, we are able to see better outcomes. And that's what this all is about. So
Mhm.
I love that. I'm so glad you
Absolutely.
remembered that.
Oh my God, me too. Oh my God, because you're right. I would have literally remembered it at like
Yep.
9 o'clock tonight. I probably would have
Yep.
messaged you, and then I'm like, okay, I'm gonna have to add it in because
That's right. Yep.
completely lose my my train of thought, although that happens way too much lately. But
Yeah.
anyways, okay, so moving on. So what about how do you, and I don't know if there are if there's a local myofunctional therapist in your area, like talk to me a little bit about your collaboration with myofunctional therapy.
Yeah. So there actually is a local. Do you know who Pat Pine is?
Yes. Oh my God, she's
Okay.
local to you. How fun.
Yeah. I'm so lucky I've got her like right there. Yeah, so I'll see patients, I'll tell you like I even my really heavy mentalis patients that have like these oral fixation issues. You know what I'm talking about, right? The ones that like you're trying to scale the lower anteriors and that lower lip is like getting they're like, "Oh, yeah, I know." You're like, "Oh." So and the problem is they have so much calculus there because they also can't perform self-care in those areas. So yeah. So I'm just like, go see my friend Pat. She'll take care of you. And so I've got a great oral myofunctional therapist that I can refer to right away, which is just amazing. We do in Arizona have the support of lots of OMTs that, are starting to build out their own columns where they're doing entirely oral myofunctional therapy, which is really great. So I think a lot of times OMT is seen as something for pediatrics. And certainly I do believe that I think if we can get our kids breathing and get their faces developing correctly, like we'll have a completely different generation with amazing healthcare outcomes. Like I do believe that. Again, we're talking root cause dentistry here. We're talking how the skull develops dentistry. But that we also will impact our older patient, our seasoned patient population, we'll call them. And so, yes, I do work directly with Pat, and I'll send patients to her,
Oh
which
my
is
gosh,
really
that's
great.
incredible.
Yeah,
That's so
she's amazing. I saw her speak when I like first graduated from hygiene school, and she was talking about tethered oral tissues and bedwetting and all this stuff. And it's like truly when you've never heard this stuff before and you're like, this is like voodoo. I, First of all, this can't be real. And then you look up the data and you're like, okay, this is real. This is so crazy. How come we're not talking about this, people? How come we're not talking about it? It almost gets infuriating than when I see a young mother who's struggling and her baby's not latching. And you're like, how come nobody's talking to you? You got a lactation specialist who didn't once, they're talking to you about the problems
Mhm.
that you're like, what's wrong with your nipple or whatever, instead of looking at the baby. You know
Right.
what I'm saying?
Right. Yeah.
So I think there's opportunity for us to also make it okay make it
Mhm.
okay to have I have patients that come in with serious malocclusal issues and vaulted palate, and they've lived their whole lives this way, and they've got periodontal issues because they're mouth breathers, and and just the whole thing, the cascade has happened. And these patients are doing their best. They're really trying. They're brushing, flossing, using the water, all the stuff. They're trying. Now we get to take a step back and go, of course you're trying. You're doing all the things, but you've
Mhm.
been set up for failure because look
Yes.
at what's going on, right? So we're talking root cause. We're talking whole body health. And to
Yeah.
your point, this right now it's such a juicy time where people are looking at that. People would rather figure out what dosage of magnesium they should take now so that they don't have to have cardiovascular issues down the road. They're drinking kombucha and kale salads and hot yoga, and we're doing the preventive things now so people are ready for it. And that means dentistry, we got to suit up and be there to provide that support.
Absolutely. Oh my gosh, Katrina, this was just absolutely wonderful. Is there anything that you want to leave the listeners with before we wrap up?
I honestly, I would just say, like, truly, I know that a lot of times this airway oral myofunctional therapy, all the stuff that we learn about it does feel overwhelming. I hope that if nothing else, starting to ask those questions and drip things in. You see these patients every 3 months.
Yeah.
Take a new thing and add it every 3 months. Drip it in. It's okay. What you're doing is doing so much to support the health of your patients. And if I can leave you with this, from a person who lost her parent to the community, please don't be afraid, because I would have given anything for anybody else to have looked at my mom and said, something is just not right here. And I think we need to have someone else take another look.
Yeah.
So please consider the power of that.
And thank you for sharing that story with us too. I really appreciate that. Where can listeners find you? What is your Instagram handle? If they don't already know,
Yeah.
it's fun.
Yeah, come find me on Instagram. I spend a lot of time putting content out there. I'm the Dental Wine Hygienist on Instagram and Facebook. I also do some stuff on LinkedIn. You can find me on my website, www.katrinasanders.com. If you click on the Learn page, I've got tons of fun content on there, articles I've written, webinars I've done. So, feel free to kind of take a look around. And thank you so much, Brittany, for this amazing opportunity to be on the pod with you.
Oh my gosh, thank you. My pleasure.